if this bill were to become law and the Secretary were to adopt these breast cancer screening recommendations as part of the essential benefits package, Pennsylvania would either have to change its benefit mandate law or reimburse the government for the added cost of screening this population. These recommendations should be a wake-up call that government-run health care will come between patients and their doctors. I look forward to hearing our distinguished witnesses. Thank you, and I yield back my time.
Thank you, Mr. Pitts. The gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman, very much for the hearing today, because it not only gives us an opportunity to further understand the recommendations as to breast cancer screening, but it affords us an opportunity to raise awareness about the real issue involving women's health in America, and that's access to care, plain and simple. For women in America, access to care, affordable health care, including screenings of all kinds, eclipses the debate over what age women and their doctors should begin routine mammograms. For millions of women across America, this debate has no application whatsoever. They're not receiving screenings at age 50. They're not receiving screenings at age 60. They simply do not have access to affordable health care because our health care system in this country is broken. It's very basic. We know that if you do not have affordable health care, you are less likely to receive the vital preventative screenings that women with insurance have. The American Cancer Society reports that in my home state of Florida, if you don't have health insurance, you're simply not going to receive any screening whatsoever. Women in this country just do not have access to affordable care. Maybe 1/4 of women in the state of Florida that do not have health insurance will receive some mammogram during the age 40 to 60. And it is much worse if you're African American or Latina. The disparities in screenings, diagnosis, treatment exist, and I think this is the critical issue that Donna Christensen has raised that really deserves a great deal of attention and debate, and it is the proper place for our outrage over women's health in America, because regardless of your insurance status, if you're African American, you are 1.9 times more likely to be diagnosed with an advanced stage of breast cancer than white women, and Hispanic women are almost 1.5 times more likely to be diagnosed than white women. So the real concern here and the proper place for our outrage is access to care in and of itself. Our broken system prevents millions of women in America from even being part of this debate over screening. Fortunately, due to the efforts of many over the past year, we are on the road to correcting this problem. And I hope that we can focus on the true issues of our broken healthcare system in America that affects, yes, breast cancer screening, but really is the heart of the problem in our fight to making America a healthier country. Thank you.
Thank the gentlewoman. Next is the gentleman from Michigan, Mr. Rogers.
Thank you, Mr. Chairman. You know, science is a whole host of disciplines, and math is one of them. And when you look at what the task force recommendations have done, it is absolutely disingenuous to say cost didn't play a role in it. Let me quote you from the American Cancer Society. The task force says that screening 1,339 women in their 50s to save one life makes screening worthwhile at that age. Yet the task force also says that screening 1,904 women ages 40 to 49 in order to save one life is not worthwhile. When you look at their executive summary, clinical breast examination specifically talks about costs. The principal cost of a CBE is the opportunity cost incurred by clinicians in the patient encounter. Clearly, cost is a consideration. They did it with digital mammography. Digital mammography is more expensive than film mammography, and talks about the cost-benefit analysis of that as they work their way through. Magnetic resonance imaging. Magnetic resonance imaging is much more expensive than either film or digital mammography. To say that cost was not a factor in this is not being honest. It's just not. It clearly was the reason. And to say, well, they don't have any authority, wait till that insurance company comes out and says, well, we based it on this task force, a government task force recommendation, says I don't have to pay for mammography for a woman between the ages of 40 and 49. That's where we're going. Matter of fact, in your 2,000-page bill, that's exactly what you do. The Health Benefit and Advisory Committee is created to do exactly that. And how do we know that? Because the National Institute of Clinical Effectiveness, the NICE board in Great Britain, is the very organization that limits things like pap smears. They raised it from 23 to 25 for young women. Why? Why did they do it? Because science told them? Nope. To save money. And what the math part of your science equation is, we think that we're willing to accept that more women will be diagnosed later on, in later stages of cancer. We're willing to accept a higher mortality rate to save money. That's what this report says. And that's what we're getting ready to foist on the American people. That is not a scare tactic. That's reality. And it happens in Great Britain. And it happens in Canada. And it happens in France. And what we are saying is we can and should do better. I am a cancer survivor because of early screening. I know Mr. Blunt is a cancer survivor because of early screening. Why we would foist this kind of an ugly system and hide behind the fact that we will have more deaths, more mortality because of cancer, because of it, is beyond me. What we're saying is this 2,000-page bill and its 118 new boards, commissions, and other government agencies that will dictate your health care policy is wrong. And we can and we should, by these women in their 40s, do much better. And I would yield back the remainder of my time, Mr. Chairman.
Thank you, Mr. Rogers. Next is, I'm having a hard time seeing who's here. The gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman, for moving so quickly to convene a hearing on the recommendations of the Preventive Services Task Force. I appreciate it. This committee has talked a lot about the need for evidence-based science over the last year, but it is important, particularly when it comes to something as critical as breast cancer screenings, that we do look carefully into the justification for these recommendations and their ramifications for individual women. Many of my constituents have questions, as do I, and I look forward to asking them. But I do want to say right now that this is not something that should become a political football or, in my view, an attack on the need for health reform that guarantees access to comprehensive health care for women. We all want to ensure women, especially women threatened with life-threatening diseases like breast cancer, and make sure that they have access to the health care that they need without pre-existing condition exclusions, gender rating denials that exist today. But among the questions that have been asked is, how do we reduce the number of unnecessary screens while ensuring that we do not provide disincentives for mammograms that will save women's lives? How do we empower women to ask for a screening when they suspect a problem? How do we build on what we know today to ensure that we're getting the research and science around breast cancer prevention and treatment right? What improvements are needed to obtain more accurate screens? How do the grades provided by the task force mesh with its recommendation that doctors and their patients be allowed to make individual choices, particularly when it comes to high-risk women? And how do we make sure that inadequate insurance coverage or high cost sharing don't prevent barriers to screening and all appropriate follow-up care? Women across the country are concerned about getting access to mammograms and other essential services, and women's groups across the nation have endorsed comprehensive health reform for this very reason, because they know that millions of women's lives depend on it. I'm eager to hear from our witnesses and discuss the task force's recommendation. And again, Mr. Chairman, thank you for having this hearing. I yield back.
Thank you. Gentleman from Arizona, Mr. Shadegg.
Thank you, Mr. Chairman, and thank you. I want to also thank you for holding this hearing so quickly on this important topic. I believe I've mentioned to this committee before that my oldest sister is a 20-year breast cancer survivor, so I have a keen interest in this topic. The breast cancer treatment guidelines released on November 16th by the U.S. Preventive Services Task Force have created a firestorm across the country, giving rise to concerns about women's access to life-saving screening. Some have commented that these recommendations are merely guidelines for insurance companies and government officials trying to assess the relative value of mammography, clinical breast exams, and breast self-exams. In a written statement, Health and Human Services Secretary Kathleen Sebelius said the guidelines had caused a great deal of confusion and worry among women and their families across this country, and stressed that they were issued by, quote, an outside independent panel of doctors and scientists who do not set federal policy and don't determine what services are covered by the federal government. I am here to tell you today and to tell every woman in America that under this bill, H.R. 3962, which has already passed this Congress, that statement will not be true. Indeed, under this bill, the recommendation of this task force would become binding law. And if so, it would be devastating to access to mammograms and nothing short of catastrophic for women's health in this country. In their recent report, mammograms for women aged 40 to 49 were given a grade of C. Under this bill, any procedure given a grade of less than A or B cannot be covered by the public plan. So the women that my colleague worried about who have no access to care today for mammograms could not legally get mammograms once this bill becomes law. The panel also found insufficient evidence to determine whether it's worth screening women over the age of 74. Again, because the grade was neither an A nor a B, it was an I, insufficient. Under this bill, those women could not get mammogram screening legally under any public plan. But it's important to understand precisely how far this bill goes, because it does not just prohibit mammogram screening. If this were the finding of this same task force after H.R. 3962 becomes law, it would prohibit private insurers, make it illegal for private insurers to provide mammogram coverage to women in these age groups. That's what the law says. Let me explain. Under the House bill, private insurers can offer 4 health plans. 1, a basic plan. 2, an enhanced plan. 3, a premium plan. And 4, a premium plus plan. Under Section 303 of H.R. 3962, women purchasing insurance under the first 3 categories, basic, enhanced, or premium, would not be allowed to purchase because the insurance company would not be allowed to offer a policy covering mammogram services. That's right, it would be illegal for a private insurance company in any one of those first 3 categories, basic, enhanced, or premium, to offer coverage for mammograms because mammograms were not given either an A or a B rating. With regard to the top category, Premium Plus, an insurance company could offer coverage for mammograms, but if and only if the Health Choices Commissioner specifically allowed the policy to cover mammograms. Now, I don't suspect that many of my colleagues on the other side of the aisle understand that aspect of this bill, and I hope that before this bill or anything like it were to become law, they would study it closely and recognize what is wrong with it. Certainly having the government prohibit people who choose to be able to buy mammogram coverage is not what was intended by the authors of this legislation. But in fact, that's what the bill does. The government would prohibit millions of women from buying coverage for mammograms. The government would forbid private plans from offering mammogram coverage to millions of women. Poor and middle-class Americans, by force of law, would be prohibited from getting mammogram coverage under the insurance exchange
Gentleman is 2 minutes over. I've let
created
you
in
go
this
on.
bill. I thank
Like
the gentleman for his indulgence and hadn't realized I'd gone over time. Thank you.
Thank you. Gentleman from Maryland, Mr. Sarbanes.
Thank you very much, Mr. Chairman, for holding this hearing. I expect we're going to hear a lot about rationing today from the other side. To me, the discussion today isn't about rationing. It's about being rational in looking at all of the evidence that's available to us and making smart decisions about what kind of treatment we should deploy and what kind of coverage there should be. And I think the jury is out on this. That's why we're having the hearing. There have been recommendations that have been put forward. They appear to me to be based on very extensive studies, research, and science. And I think we ought to approach them with an open mind. I'm glad we're having this hearing. I think this is exactly the kind of thing we should be doing. And the fact of the matter is that as science advances, it causes us to revisit treatment. And that's a good thing. Now, there may be other considerations at play here. One of them is clearly the high attention that there is to mammography screening and the education effort that is going on with women across this country to make them more sensitive to this as a screening tool. So all of those considerations ought to be fed into the mix, and I would expect that the Secretary of HHS will be considering all of those things going forward. But to put our head in the sand and not look at the science, it seems to me, would be a serious mistake. So we ought to review these recommendations with a sober and dispassionate consideration. I think that's what we're called upon to do. I would assume that that's what the Health Benefits Advisory Committee would do in receiving recommendations from any other government body. The notion that one government, and we've heard this theme again as well today, the notion that one government body will accept without any kind of independent judgment or review the recommendations of another government body, I don't think makes any sense. I think that the Health Benefits Advisory Committee will look at all the factors in determining what ought to be the policy when it comes to treatment. So I think this is a good conversation to be having, and I thank the Commission for putting the recommendations forward, for basing them on science, and now we're going to have to consider those in the light of many, many factors in judging how to move forward. So I look forward to the testimony of the witnesses, and I yield back my time. Thank you.
Thank the gentleman. Gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman, and I want to say thank you so much to our witnesses for being here. I am really appreciative of the opportunity for us to have this hearing today, and I have a formal statement I will submit for the record, but I do want to make a few comments as we begin this. This is an issue of tremendous concern to me. I think that all of us are concerned about the welfare and the health of women. We're concerned about what you all as the task force brought forward. Sure, we're concerned about the science, and I want to discuss with you that science, where you drew that from and your process. I also want to explore with you your task force structure and look at the linkages that you bear and what would happen if H.R. 3962 were to be passed and read into law. You all have a portfolio of 105 topics. That gets to the heart of the issue. Because when you start reading on H.R. 3962 on page 1296 into Title III, and you look at Section 2301 of this bill, the decisions you make do end up having the weight of law placed behind them. And when you read specifically on pages 1317 and 1318, you see exactly what is going to happen with your recommendations. And then you go in and you look at how it becomes the standard of the law. So I encourage everyone to take this bill down and read it, and read that title. Look at Section 3101. Look at Section 2301. Go back and look on pages 110 to 112 at how what you do and how you give priority and preference to certain treatments and certain categories is going to carry the weight of law. Now, it is of concern to me when I hear statements made by members of Congress that we are going to deploy certain treatments or certain health care. That ability should rest with the patient and their physician. We do not need a bureaucrat in that exam room. And yes, indeed, when you read this bill, we do have concerns that it will lead to rationing, because decisions appear that they're being made on cost and not on health care. So I welcome you all. I appreciate your time. We're going to have a lengthy number of questions. And Mr. Chairman, I yield the balance of my time.
Thank the gentlewoman. Chairman Dingell, gentleman from Michigan.
I flew back this morning from Michigan hoping to have a rather informed hearing on a very important point. I find that I have come back to listen to some fairy tales coming from the other side of the aisle. And I find myself offended by the lack of attention that my Republican colleagues have given to the health bill. And I find myself very much affronted to listen to the kind of distorted logic and reasoning with which I am being afflicted as I enter this room. Now, I have great affection and respect for my friends on the other side of the aisle, and I'm willing to assume that their behavior this morning in making the comments I am hearing about these recommendations and how they will play with the bill is bottomed on a lack of attention, study, knowledge, or diligence in understanding either the bill or the recommendations of the U.S. Preventive Services Task Force. It's been a little bit like listening to the fairy tales of the Brothers Grimm. But to set the record straight, I want my colleagues to understand that the bill does not, in its provisions, behave as my Republican colleagues would have us believe. It does not use these kinds of recommendations to suppress treatment or interfere with the relationship between the patients and the doctors. This is the kind of scare tactics that I have heard from that side of the aisle, always with great personal offense. They talked about how we're going to pull the plug on grandma, how we're going to push euthanasia forward, how we're going to deny health care to deserving people because of this legislation. These recommendations that we're going into this morning are recommendations, nothing more. And to say anything different than that is either to transmit the grossest kind of carelessness, and I hope this is not the case, or just plain outright deceit. It is time for us to look at these recommendations as they are. The recommendation of a scientific panel created to make advice on what is the best medical practice and how we can see to it that we best protect our women with regard to things like pap smears and mammograms. Now, I'll yield to no one on either subject because this committee and the Oversight Subcommittee when I was chairman of each, were responsible for seeing to it that both mammograms and pap smears were made in the safest way for the benefit of patients. I lost a mother to cervical cancer, and I've lost lots of friends to breast cancer and other things. And I am grossly affronted by the statements that I've heard coming from the other side, in which they tell us how these recommendations and the health bill on which we are working so hard are going to deny women mammograms, proper mammography, and pap smear and other needed services. That is offensive. It is just plain wrong. It is absolutely false. And I would urge my friends on the other side to go off and take a look at the bill, to read it carefully, and if they need any assistance in understanding what the bill does, I will be happy to volunteer to provide time so that they may come to have a better understanding of what the bill does, and they may then make more informed statements on these matters. We need to deal with our health problems in a responsible way. We need to see to it that we address the honest defects which are in the bill, but not to manufacture a lot of fears and faults which do not exist. I am affronted, Mr. Chairman, and I hope that this record and this hearing will correct some of the unfortunate misapprehensions and misstatements that have been flowing thickly from the other side of the aisle this morning. I ask unanimous consent to revise and extend my remarks.
So ordered. Thank you, Mr. Chairman. Gentleman, our ranking member, the gentleman from Texas, Mr. Barton.
Thank you, Chairman Pallone, for holding this hearing. I listened with great affection and with great interest to my good friend from Michigan, former Chairman and current Chairman Emeritus Dingell's opening statement. I think it goes without saying the personal esteem and the professional respect that I have for him. Having said that, there are no fairy tales being told on this side of the aisle this morning. Here's the bill. Passed the House. I want to end this bill on page 1762. The U.S. Preventive Services Task Force is given the authority, and I quote, to determine the frequency, the population to be served, and the procedure or technology to be used for breast cancer screenings covered under the Indian Health Service. In Section 303, the legislation states, and I quote, the Commissioner shall specify the benefits to be made available under the exchange participating health plans, end quote. In plain English, Mr. Chairman, what this means is the new Health Choices Commissioner will determine what preventive services, including mammography, are covered under the health insurance that's in this bill. Now, we also know that the U.S. Preventive Task Force is an outside independent council of doctors and scientists who make recommendations. They do not set federal policy, and they don't determine what services are to be covered by the bill, but their recommendations are going to be seriously listened to. Now, I have an aunt who passed away in her early 50s as a consequence of breast cancer. I have a sister who was diagnosed with breast cancer in her 30s. Luckily, received proper treatment, had a mastectomy, and so far, for the last 10 years, is cancer-free. I have a wife, beautiful wife, who's under the age of 50, and she has annual mammograms every year. I have a good friend who was just diagnosed with breast cancer, who's in her mid-40s. Again, she's undergoing treatment. Hopefully she's going to have a good outcome. To have a task force make the recommendation that has been made, and to have in this bill the authority that's given to various unelected bureaucrats to make health care decisions, including coverage and frequency, in my opinion, is wrong. It's wrong. Now, on a bipartisan basis, this subcommittee and the full committee repeatedly has passed bills increasing and supporting the early detection of breast cancer, the prevention, the research. I mean, we do it almost every Congress. So we're starting down a path, in my opinion, of socialization of medicine in this country with the passage of this bill out of this committee, with its passage on the House floor. It's awaiting approval in the Senate. This is an excellent time to hold this hearing. I appreciate the chairman and the full chairman, subcommittee and full committee chairman's personal attendance. But let's don't talk about fairy tales. Let's talk about the facts, the plain English of these bills. And if we continue to agree rhetorically, then we need to begin to make substantive changes in the legislation to prevent what we all say we oppose. We don't want rationing of health care in America. We don't want to intervene between the doctor-patient relationship. We don't want young women, or for that matter, more mature women over the age of 74, developing breast cancer because they're not allowed a mammogram. My good friend to my right, Mr. Rogers of Michigan, had an amendment that was passed at committee that explicitly prevented the rationing of care, and it mysteriously disappeared in the bill that got reported out of the Rules Committee. In the dark of the night, some staffer on the majority side, or maybe a member, I don't know, decided that the will of the committee didn't mean anything. It disappeared. Maybe we need to put that back in. I don't know. So, I have great respect for this committee. I have great respect for the leadership on the committee. But let's don't talk about fairy tales when we can read these bills. Now, I'm not saying the bill's a fairy tale, but I will say the bill is not reflective of the policy that members on both sides of the aisle say they support. With that, Mr. Chairman, I yield back.
Thank you. Next is the gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, and I appreciate the opportunity that you have in so quickly dealing with this. First of all, I want to thank the Chairman Emeritus for his offer for the Chairman Dingell willing to conduct a class on remedial health care comprehension. And my only question is, it going to be mandatory or permissive? Hearing my colleagues on the other side talk about unelected bureaucrats, unelected insurance companies do this every day, right now. And I'll give you an example. When I moved to be a member of Congress, my wife had been getting annual mammograms, and yet our new insurance in Congress refused it after the first year. And she was a survivor. Her mom was a 40-year survivor of breast cancer. And so she fit the exception. And it took me, as a member of Congress, saying I can't practice law, but believe me, I will file suit against our carrier if they don't continue to pay for those mammograms. You have to fight for the care that you want. And to say that the House bill that passed would set up this unelected group to do it, it all rests on our shoulders. And I think that decision ought to be made by elected officials. Now, this group will take recommendations from everyone, but ultimately it's going to be our decision, and we'll continue to provide legislation to have minimum benefits. And the statement I have, in 2002, the task force changed their breast cancer screening to a grade B to recommend mammograms every 1 to 2 years for women 40 to 75. That was only 7 years ago. And yet now the task force is making it change. 2 weeks ago, they revised it and made it a grade C. And that's the issue, I think, that my colleagues are talking about, that women at age of 40 would not be automatic but should not be denied. And again, it does go back to the doctor and the patient's decision. And I have, in fact, doctors on both sides. I have doctors tell me all the time that they have battles with insurance companies saying we need to do this, and the insurance company won't allow it. And they're the ones that are practicing medicine. And that's a battle that has to be fought every day, no matter what happens if we pass a national health care bill. But to use this opportunity to pick at the national health care bill, I think is interesting, because the task force will be given the opportunity to clarify their statements, and I'm glad we have the testimony here today. The adverse reactions to the poor wording of the task force recommendation obviously is not going unnoticed by our committee and the members of the committee. In fact, I contacted and we've been contacted by a number of constituents in my district, including MD Anderson Cancer Center in Houston, about the recommendations. They were very public. They're opposed to the task force recommendations. They'll continue to recommend it, along with many, many other groups. And luckily, the state of Texas has a mandate that all private insurers must cover annual breast cancer screenings beginning at the age of 40. But this new screening recommendations will cause some access problems for barriers for women. The topic is also especially sensitive because the Reform Bill 3962 states that the U.S. Preventive Task Force recommendations A and B are mandated benefits, and the bill also includes report language saying A and B recommendations for a floor for benefits, not a ceiling. The A and B are a floor. So the task force recommendation will be considered that, but the decision could be made still no matter what the task force says. So that's what we're here today to talk about. I have concerns about jeopardizing access to preventative screenings for women, especially since I represent a majority Latino district that's medically underserved, and I've worked for years in Congress to expand the coverage of mammograms in our community and for primary and preventative care services. I'd like the fact that the task force is an independent commission and is designed to keep politics out of medical recommendations, because I can be an expert for 30 seconds on anything, but I do depend on the experts to be able to make those decisions. And again, I look forward to the testimony, Mr. Chairman, and I ask for unanimous consent to my full statement be placed into the record.
Without objection, so ordered. Thank you, Mr. Green. Next is the gentlewoman from North Carolina, Ms. Myrick.
Thank you, Mr. Chairman. Thank you for holding the hearing today. I understand that scientifically and statistically this report information is not new, and I know that mammography is not perfect by any stretch of the imagination, but I want to talk to this whole report from the preventive side, because to me it's sending the wrong message to women. It's saying you don't have to be vigilant, you don't have to take care of yourself, you don't have to do preventive care. And the reason that concerns me is I'm a 10-year breast cancer survivor. I'm one of those that persevered literally to find, my own cancer because I knew something was wrong with my body. And I had, good doctors who helped me. But because of that, I'm here today. And we all know that earlier detection means longer survivals. I mean, that's a no-brainer. So many women really say to me, I don't want to get a mammogram, it hurts, or whatever, I just don't want to do it. I heard that over and over again ever since I started to get active on this issue. And then a lot of women have told me, I don't want to know. I really don't want to know if I have cancer. Well, my whole point in this is, you better find out sooner rather than later because of what I said before. So I'm very concerned that we are saying, hey, you don't have to take care of yourself. Women look for an excuse not to do this anyway and not to do self-exams. And especially, younger women today. There are so many younger women in my area that are in 20s and 30s getting breast cancer. They have their own support group. And that never used to happen. So when we talk about what we need to do, I hope that we will very seriously consider that, you know, and I'm glad the panel's going to be here to explain why they did what they did. But I know that some of the groups are going to continue to recommend they do the same thing. And with digital mammography now, things have changed, especially with younger women. So, Mr. Chairman, I appreciate this opportunity very much, and just look forward to hearing the recommendations from the panel.
Thank you. Gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. I want to appreciate your calling this hearing of the Health Subcommittee to discuss what is both a deeply personal and deeply political issue for myself and, as you've heard, many of our colleagues in this room. The United States Preventive Services Task Force was authorized by Congress to deliver recommendations regarding the efficacy of clinical preventative services. Ideally, these recommendations will be used to inform primary medical care. On November 16th, the task force delivered new recommendations regarding breast cancer screenings, incorporating the most extensive scientific evidence available. Among their more controversial findings were the grade C recommendation for mammography in women over 40, which means that because the science does not point to any significant harm or tremendous benefit, that the provision of the services should be a decision between an individual and her doctor. An independent, rigorous examination of the science behind clinical preventative services is an essential part of delivering effective health care. The task force was doing its job. And as they may admit today, they could have done much more around such a sensitive topic by educating and explaining their recommendations to women across the country. They could have engaged community and advocacy groups to be messengers of this information rather than combatants. Moving forward with additional recommendations in sensitive areas, I would encourage them to do just that. I came away from this report and the surrounding controversy with two additional thoughts that I would like to quickly share. First, we clearly need better screening and diagnostic tools. Mammography is not a precise enough tool. We need advancements in technology that can help us understand what conditions require further tests, what requires treatment, and how we can best help women live long and healthy lives. Some of these advancements in technology are being developed in my home state of Wisconsin. Tools to help us identify types of tissue with more precision, improving the efficacy of an X-ray screening for breast cancer. My second point is that we urgently and desperately need health care reform. We must ensure that every woman and every American has access to a regular source of care. If the best approach is to discuss the option of mammography or other screening with your doctor, you have to have a doctor. The villain here is the lack of coverage and access to care. Otherwise, women who are shut out of the health care system, whether by stigma or lack of resources or even abusive and discriminatory insurance industry practices, these women have the potential of dying of breast cancer or other conditions before we even have a chance to intervene. Again, Mr. Chairman, thank you for allowing us this venue to discuss and clarify this critical topic. It has bearing not only on the health of women, but the health of all Americans.
Thank you. Gentlewoman from Colorado, Ms. Daggett.
Thank you very much, Mr. Chairman. I'll submit my full statement for the record. I just want to say that, as Mr. Sarbanes said, we've got to look at science here. And we've got to look at the recommendations based on science, which, you know, sometimes I feel revolutionary in Congress saying that, but that's what we need to look at. All of this excitement on the other side of the aisle about how these recommendations are going to be implemented. First of all, as Mr. Green said, it's not a ceiling, it's just a floor. But secondly, even if they were implemented, most of them probably we wouldn't object to. The recommendations say, number one, the decision to initiate regular screening mammography in women aged 40 to 49 years should be an individual one, accounting for patient context and values. rather than a population-wide recommendation for routine screening. That makes sense to me. Number 2, biennial screening mammography for women aged 50 to 74 years. Number 3, insufficient evidence to assess the additional benefits and harms of screening in women over 75 years or older. And then the others. So really, if you actually look at the recommendations, they probably do make some sense from a scientific standpoint. But I've got to say, it is no wonder why the women of America are unbelievably confused as to what these recommendations are saying. Because what they are saying is most women need to talk to their care provider, and they need to figure out for themselves, based on their health and their family history, what is appropriate for them. It's not a one-size-fits-all testing. That makes sense to me. But if you look at the 24-hour news cycle, that's not what's being said to people. They're scared, they're confused, and when you add the misinformation that we hear from some of my friends on the other side, they're triply confused and scared because they think now when we have a health care plan that applies to everybody, suddenly they're going to be told that they don't need that they can't have tests that they need. And that is simply not the case. And so Mr. Chairman, that's why I came down and sat through all the opening statements and am looking forward to the testimony, because I think we really need to clear it up. What is it that we are saying should be done with mammography and testing for women, and what is it that women need to be talking to their physicians about? Ultimately, it's going to be the decision of the physician and the woman what they need, and they need to figure that out, and then they need to feel secure that they're getting the level of testing that they need. Thank you, Mr. Chairman.
Thank the gentlewoman. Next is the gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman, for taking the time to hold a hearing on this very important issue. Cancer is a terrifying specter for all Americans, and almost all of us have had a loved one or a friend who's been affected by it. It certainly is a disease that strikes fear in the heart of all of us. And I want to preface my remarks by saying that I have heard some things from the other side of the aisle that have made a lot of sense, and I specifically point to Congresswoman Myrick's comments, and I find them very consistent with those just provided by my colleague from Colorado, Congresswoman DeGette. But we've heard some things from the other side of the aisle today that I think cause us, or certainly cause me, considerable concern. I think that it's wrong to use that fear that we all share of cancer to intimidate the people of this country into fear of comprehensive legislation that, as some of our witnesses will testify today, is good for people with cancer. In following up with some of the remarks made by Chairman Dingell, there are some things this bill does not do that need to be clarified. These task force recommendations will not lead to rationing care. That is simply not true. And I think that it's tactics like these that weaken the faith of the American people, not in any one particular party, but in the institution of Congress. Nothing in this legislation prohibits insurers from covering mammograms. In fact, the legislation gives the Secretary leeway to add to the minimum benefits package as needed. I think it's disingenuous to, on the one hand, defend the status quo, which sees the insurance industry every day making decisions about the lives of their insureds based on strictly financial considerations. And then, on the other hand, condemn a system because you speculate that these kinds of recommendations will lead to the rationing of care. Second, what this bill does do is it provides the benefit of insurance to millions of Americans that don't have it. And following on with what Dr. Christensen mentioned earlier, it's not just those Americans that don't have insurance that will benefit from this bill when it comes to preventative care and access to mammograms. It's those who have insurance but can't afford the co-payments, specifically those who are indigent or middle-class Americans. That makes a difference for them. This bill makes preventative care a basic and fundamental right for every American. That means, again, that my constituents, the 65,000 of them that have no access to coverage right now, and tens of thousands more who can't afford co-pays, will now have access to things like mammograms when they wouldn't have otherwise had that. These are questions that we all should be asking. What is the net benefit of this legislation to our constituents? Rather than jumping to irrational conclusions, adding confusion to the public, and politicizing an issue which should transcend politics, we should be asking these rational questions, again, as my colleague from Maryland indicates, based on reason and science. With that, Mr. Chairman, I thank you once again for calling this hearing, and yield back.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, for holding this extremely important hearing on the recommendations from the U.S. Preventive Services Task Force on mammograms for women in their 40s. As we've all heard and has been discussed here, the task force is no longer recommending routine mammograms for women in their 40s. And as someone who cares deeply about women's health, I, like others, was surprised by this change. Breast cancer is, to say the least, a terrible disease. It's the leading cause of death for women between ages 20 and 59. We all know people who have been touched by breast cancer, people that we love and care about. And we all know people who have benefited from early detection. So this is such an important hearing, and I look forward to hearing the discussion of the panel. And what the recommendations basically are is that a woman should talk to their doctor or her doctor and make decisions accordingly for their care. But many women, as has been pointed out, don't have doctors, and many women don't have access to health care. And women who should get mammograms either under the old recommendations or the new recommendations do not get the mammograms. In 2007, only 70% of the women in the country who should have been screened for breast cancer were screened for breast cancer. And part of the reason women, whether they're 40 or they're 60, are not screened is because they do not have insurance. And because they don't have insurance, they don't have access to the care that they need when they need it, including preventative care. So let's be clear that providing access to health insurance means providing access to preventative care, which means saving lives. So what's important is that patients and doctors are able to consult and access the care that that patient needs when that patient needs it. And that the patients and doctors together will decide the best course of care, whether that includes a mammogram. But in order to do that, people have to have access to doctors. Women of all ages under the health care bill that has been passed by this House will have improved access to coverage. That should not be lost, and it certainly should not, discussions otherwise, representations otherwise, should not be used as we debate and discuss this very important issue to derail efforts to give women access to the health care that they need in this country. I don't think that that serves women well. I don't think that serves our country well. And frankly, I find it outrageous. And I yield back.
Thank you. Gentleman from Iowa, Mr. Braley.
Thank you, Mr. Chairman, and thank you for holding this important hearing. I also want to commend my colleague, the gentlewoman from North Carolina, for her eloquent and thoughtful statement on a very important topic. And while I disagreed with what some of my colleague from Georgia said, I have great respect for his real-world experience on women's health issues and appreciate the concern he brought to this hearing. But I also want to talk about the comments that were made by the Chairman Emeritus and others on this committee. if people don't believe that rationing takes place right now in our private insurance system, every day in every state, in every congressional district, they are sorely misguided. It does happen every day under the current system, which is failing to meet the needs of the American people. I'll give you a good example of a friend of mine who was diagnosed with prostate cancer and conferred with his physician on treatment options and agreed that proton beam therapy was the best choice of treatment for him. And he went to his private insurance company, which also is the Medicare administrator in my state of Iowa, and his treatment was denied on the basis that it was experimental. Well, guess what? Under the Medicare plan that same private insurance company administered, it was considered non-experimental, and even though he was eligible for Medicare because of his age, he was still covered by a private plan through his employer and was denied coverage for the same treatment he would have gotten if he had been a member of Medicare. That's what's wrong with our broken health care delivery system, and that's why comparative effectiveness research is such a critical part of a rational discussion about health care policy making. In an earlier hearing in this same subcommittee, I talked about a hearing that took place in this very room years ago when a researcher advocating high-dose chemotherapy with bone marrow transplant for metastatic breast cancer patients was the only path to cure for those women, even though it had not been tested by rigorous academic research. Then, years after that, we came to the realization that many women were actually harmed and died because of being subjected to that treatment. And that is why, by the way, it is so important that the plain language amendment that I put in the health care bill be implemented in people dealing with health care issues. I think that in its position paper, the U.S. Preventive Services Task Force highlights why that is so important. They indicate on one page of their statement that the problem was a matter of communications because they did not say what the task force meant to say, that the communication of the mammography screening recommendations was poor. Well, I agree with that, and all you have to look is the next two sentences to find out why. This is what two of the sentences say. We said is that screening starting at age 40 should not be automatic, nor should it be denied. That doesn't make sense. The next sentence says, what we are saying is that a decision to have a mammogram for women in their 40s should be based on a discussion between a woman, her doctor. If you don't communicate for your intended audience in language that they can comprehend easily, these barriers of communication between highly technical, scientific, and medical information will be a problem. But the debate we're having is a healthy debate about what the most effective use and treatment for breast cancer patients is, and that's what we need to focus on going forward. And I yield back my time.
I thank the gentleman. Next is the gentleman from Utah, Mr. Matheson.
Thank you, Mr. Chairman. I'll be brief because I'm looking forward to hearing from our two panels on this topic. In my state of Utah, the incidence of breast cancer is lower than most states. However, our mortality rate is high because women in Utah are diagnosed in cancer's later stages. As a witness on our panel notes in his testimony, the recent recommendations provided by the U.S. Preventive Services Task Force on November 16th have sparked concern and disagreement among providers, patients, families, as well as sparked a public discourse that has led to further confusion and anxiety. As we can see from the testimony before this committee, there is not consensus on screening protocols, but there does seem to be consensus that any screening and treatment discussion is an individual one between a provider and a patient. So I hope today's hearing can provide concrete information on the evidence-based decision-making processes of the task force. But I'm also interested to hear from the cancer community and medical providers on their next steps for outreach and patient education on the benefits and limitations of mammography screening. Thank you, Mr. Chairman. I'll yield back my time.
Thank you. I believe that concludes the opening statements by members of the subcommittee. So we'll now turn to our witnesses, and if our first panel would come forward, I would appreciate it. Thank you. We have two witnesses, both from the U.S. Preventive Services Task Force. To my left is Dr. Ned Kalange, I hope I'm pronouncing it properly, who is chair of the U.S. Preventive Services Task Force. And next to him is Dr. Diana Petiti, who is vice chair of the U.S. Preventive Services Task Force. Now, I'll just mention, as I think you know, that we have 5-minute opening statements as from you. They become part of the record, and each of you may, in the discretion of the committee, submit additional statements in writing for inclusion in the record. And I would now recognize first Dr. Kalange.
Good morning, Mr. Chairman and distinguished members of the committee. On behalf of our fellow task force members, we thank you for the opportunity to discuss the task force and our work. Our recently published recommendations on breast cancer screening have drawn a remarkable amount of attention. We recognize the communication of what the recommendations say was poor, and the timing of the release was unfortunate. We wish to explain the process and timeline for creating these recommendations and to clarify what we intended to say to clinicians and women. The healthcare clinician scientists on the task force fully understand, most through personal experience, the impact of breast cancer on the lives of women and their families. Our job, though, is to rigorously review scientific evidence. Politics play no part in our processes. Costs were never considered in our considerations. We voted on these recommendations long before the last presidential election. The timing of the release of the findings last month was determined not by us, but by the publication schedule of the Medical Research Journal, which peer-reviewed our work. The current task force was created by congressional mandate as an independent body with the mission of reviewing the scientific evidence for clinical preventive services and developing evidence-based recommendations for the healthcare community. Our primary audience for recommendations remains primary care clinicians. The task force has 16 volunteer termed members representing a diverse array of expertise in primary care and preventive health-related disciplines, including adult, child, preventive and behavioral medicine, women's health, nursing, and research methods. The AHRQ director appoints members from the chair's recommendations developed from a public nomination process. Given the scope of topics covered, subspecialists who consult on or care for those identified through screening by primary care clinicians may not necessarily be recruited as members, but instead are consulted to review and comment on our work at critical points in the process. Our current portfolio includes a broad array of 105 clinical preventive services that are listed on our website. We strive to update topics every 5 years, which is what prompted the new breast cancer screening recommendations. To address the topic, designated task force work group members and scientists at an evidence-based practice center collaboratively develop an analytic framework and pertinent key questions. A structured, systematic review of evidence for each key question is conducted, and a draft evidence report is created with work group consultation. Based on the evidence review and explicit methodology, the work group drafts a recommendation statement, and at an in-person meeting, the evidence and the draft statement are presented and discussed, and the task force votes on the recommendation. There is a careful attention to conflicts of interest, such that members with potential conflicts are recused from discussion and vote, or otherwise restricted in participation. Representatives of 24 partner organizations, including all primary care specialties, key federal agencies, and other key stakeholders specified in our written testimony and on our website, are invited to participate in the discussion. At 3 key points in the process, work products are sent for review and comment by the partner organizations, by subspecialty expert consultants from the relevant disease area, such as oncologists, and by other stakeholders such as subspecialty professional organizations and advocacy groups. These products include the analytic framework and key questions, the draft systematic evidence review, and the draft recommendation statement as voted on. All comments are considered in creating the final products. Final recommendation statements and evidence reviews are published in peer-reviewed medical journals. Recommendations are expressed as letter grades based on 2 factors only: the magnitude of net benefit or balance of benefits and harms of providing the service, and the scientific certainty about whether the service works. Cost and cost effectiveness are not addressed in our deliberations in making a recommendation. Over the past several years, we have discussed whether cost should ever influence a recommendation, and we have repeatedly said no. For A and B recommendations, there are sufficient net health benefits such that primary care clinicians are recommended to provide these services for all appropriate patients. If there is no net benefit or there's net harm, we assign a D recommendation indicating to not provide the service. If gaps in the evidence prevent net benefit from being determined, we assign an I statement reflecting insufficient evidence, indicating that more research is needed. Finally, a C recommendation is assigned when there is a small net benefit. For C recommendations, we recommend the patient be informed about the potential benefits and harms, and then be supported in making his or her own informed choice about being tested. The specific C language that we recommend against routine provision was intended for consideration by primary care clinicians, but unfortunately has played out in unintended ways in the public interpretation of the breast cancer recommendation. Congress, through Public Law Section 915, mandates that AHRQ convene the task force to address our mission. The role of AHRQ in the process is to support our activities and processes, but AHRQ staff and the director of AHRQ do not vote or otherwise influence our decisions. I will have to admit to the committee that breast cancer is of particular concern to me. I lost both my mother-in-law to breast cancer, and my sister is currently undergoing therapy. I fully understand this issue and have to rely on the science as we provide our recommendations. With that, I would like to turn testimony over to Dr. Petiti to testify specifically about the breast cancer screening recommendation.
I'm sorry, I just wanted to thank Dr. Colonge and now ask Dr. Petiti to begin.
Well, I'm Diana Petiti. I'm the Vice Chair of the U.S. Preventive Services Task Force. I'm a physician and an epidemiologist. I have spent my entire 32-year career as a scientist working on issues of women's health. I've published on the topic of mammography screening. I served as Vice Chair of the National Cancer Policy Board, and I have expertise in evidence synthesis, systematic review, and meta-analysis. I participated in this process from the very beginning. I would not sign off on any recommendation that I did not believe reflected the best possible use of evidence for the benefit of women. I appreciate the opportunity to clarify for members of this subcommittee the task force recommendations and the evidence and weighing of the evidence that led to these recommendations. In specific, the task force recommends the following. Women aged 50 through 74 should have mammography every other year. The decision to start regular biannual screening mammography before the age of 50 should be an individual one and take the patient context into account, including the patient's values regarding specific benefits and harms. That is, the task force is saying that screening starting at 40 should not be automatic, nor should it be denied. Many doctors and many women, perhaps even most women, will decide to have mammography screening starting at age 40. The task force supports those decisions. The task force acknowledges that the language used to describe its C-grade recommendation about breast cancer screening for women 40 to 49 did not say what the task force meant to say. The task force communication was poor. The task force is committed, really committed, to improving its communication. The task force first addressed the screening mammography topic in 1989. At that time, the task force recommended screening women 50 through 75 every 1 to 2 years. With regard to screening younger women, the task force stated it may be prudent to begin screening at an earlier age for women at high risk of breast cancer. In its 1996 guide, the task force recommendation was in favor of screening women 50 to 59 every 1 to 2 years. Mammography screening for women 40 to 49 was given a C grade. At that time, the C-grade recommendation meant insufficient evidence. In 2002, the task force recommended screening women 40 to 69 every 1 to 2 years, stating that the benefits were smaller and took longer to emerge for women who were first screened in the 40s. On November 16th, as this committee knows, the task force issued its updated recommendations on breast cancer services. I wish first to clarify that the timing of issuance of these recommendations. In late 2006, discussion of a plan for updating the recommendation began. The breast cancer topic came up for review at the regularly scheduled time. Work on the topic started in 2007. When the recommendation statements came up for a vote in November 2007, the members could not come to agreement about what to recommend because of agreement about what to say about the balance of benefits and harms. In this context, the task force asked for additional evidence from its evidence-based practice center. The task force considered this evidence at its July 14th to 15th, 2000 meeting. In making its final recommendation, the task force considered evidence identified in a systematic review of evidence for 6 key questions, the results of an analysis from the breast cancer screening consortiums, and the results of a study commissioned by the task force and conducted by the Cancer Intervention and Surveillance Modeling Network. The systematic review identified almost 3,000 studies, and 550 of these were used to make the recommendation. The final recommendations were made based on a weighing of the benefits and harms of screening mammography. The task force concluded from the evidence that screening mammography for women 40 to 64 has a benefit in reducing death due to breast cancer. The benefit is larger in older women than in younger women. And I'd like to speak specifically to the issue of harms in this net benefit equation. Preventive services are provided to asymptomatic individuals for the sole purpose of preventing or delaying morbidity, delaying functional decline, or postponing death. The promise of service delivery is net benefit, benefit minus harms. The benefits of mammography have been easy to communicate. The harms and potential harms have been difficult to communicate. The easily identifiable and commonly used definition of harm is physical injury. These physical injury direct harms are very, very small. But the task force considers as harms of a screening test not just physical harms, but psychological harms. A great deal of disagreement, of the controversy has centered on the task force use of and consideration of anxiety and psychological distress as a harm of a false positive test. In particular, the psychological distress has been ridiculed. To understand the consequences of false positive test, it is necessary to consider how women enter the screening cycle, what happens and what might happen to a woman who has a positive test. No matter how hard the concept of screening is explained, a positive mammogram screening test means cancer until cancer is proven not to exist. For some women who have a positive test, the time between a positive test and a statement there is no cancer is mercifully short. For other women, the follow-up involves more than one additional test, perhaps a clinical breast examination along with a test, a trip to a surgeon, over a period of time that is not always short, and over a period of time it is unpredictable and not within the control of the woman. Some women eventually need a biopsy. Cancer is a terrifying prospect. It carries special emotional weight because of the consequences of the diagnosis have in the past involved not only death, but the prospect of mutilating surgery. Anxiety and psychological distress in women who have had positive screening tests is amply documented in the evidence. The task force wants only that screening mammograms be done with full knowledge of these potential harms, the frequencies of these harms, and what is to be gained by being screened at an earlier compared with a later age. False positive tests are more frequent in younger than in older women's. Other harms of mammography include ones that are less well documented. Some women are diagnosed in their 40s with cancer that could have been treated just as well if diagnosed later. These women may have unnecessarily been exposed to the harms of treatment, including surgery, chemotherapy. And
Doctor, I didn't want to.
Yes.
I didn't want to stop you because
That's fine.
So important, but you're at 2 minutes over, so
I'm sorry.
keep going. But
I'm only going to say that my final statement, and mammography starting at 40 should not be automatic. The task force recommends that women in their 40s decide on an age to begin screening that is based on a conversation with their doctor and is individual. And I apologize for going over.
Well, I'm going to apologize for trying to stop you because
That's fine.
it's so important that you clarify a lot of these things, and I appreciate that. Our procedure now is that we have questions from the members of the panel. I mean, from the members of Congress, and I'll start with myself. Let me say that you've actually clarified some of the questions I was going to ask very well, but I still want to kind of review this if I could in my own mind. And if I say anything you disagree with, tell me. But I do want to ask you some questions as well. But look, there's a lot of myths out there that have been spread both today and certainly in the last few weeks since you came out with your recommendations. And the way I understand it, the current task force uses these ABC ratings. These are the same kind of ratings that would be used under the different task force that's in the legislation, the larger health care reform legislation that we passed. In other words, you are the U.S. Preventive Services Task Force. The new task force in the bill that we passed has a different name, Clinical Preventive Services, but the A, B, and the C ratings are the same or similar. But right now, these A, B, and C ratings have no force. They're just recommendations. And what some of my colleagues have said is that these insurance companies now don't have to cover A, B, or C. They don't have to cover anything. And in fact, what we're getting is that a lot of insurance companies right now don't prefer to cover any screenings, because if you do a screening and they have to pay for treatment, it costs them money, which they try to avoid. And so what I see right now is that in some cases, states have required certain screening, like my own state. But on the other hand, we heard the gentleman from Utah talk about Utah, where my understanding is they don't require any screenings. So the point I'm trying to make is that the big advantage of the health care reform bill that we passed is that H.R. 3962 will, for the first time, create minimum standards for required preventative benefits. So private insurers would be required under that bill to cover services with a grade A or B recommendation. Right now, they don't have to cover anything. What we're doing in the bill is basically saying that at a minimum, if you or your successor task force says that this is an A or B, it has to be required, which it's not now. The other thing that we do in the bill is that we say that the secretary could require a C rating also be covered under both a public option or private insurance plans. In fact, my understanding is that the new task force, the secretary under the bill, could even require a C rating under the basic benefit package. Now, that's contrary to what some of my colleagues have been saying on the other side of the aisle. And my whole point here is to say that the truth is that if enacted into law, H.R. 3962 would result in a lot of people who are not getting mammograms, pap smears, colonoscopies. A lot of people don't get that at all now because insurance companies basically don't have to do it unless the state requires it. Now, under this bill, they would have to do anything that you rate as an A or B, and the secretary could even require the C, either in the public option or in the private plan under the basic benefit package. Now, I mention this because the bottom line is that women's ability to continue to obtain mammograms increases in these House and Senate bills that are being passed and then moved. And when I look at the Republican bill on the other side, it sets no floor whatsoever. There would be no minimum required benefits for insurance to provide under the Republican bill. Essentially, it would be just like the status quo that we have now. So I don't know, I listened to the debate that we've had today, and the bottom line is that the bill that we passed in this House provides a lot more coverage, has a lot more guarantees. The status quo doesn't provide any guarantees at the federal level, nor would the Republican alternative that we've been given on the other side. Now, my question is, again, you mentioned that when you recommend a C, it says that it has a small net benefit and women are supposed to make their own decisions. So you made it quite clear today that even if it's a C, there is some net benefit, and the secretary could decide under the new bill to say, okay, that's going to be required as well. So you're not in any way, with this C recommendation, saying that this screening is not a good thing. In fact, you're actually saying there is a net benefit, but you would like individual women to make that decision with their doctor because it's only a small net benefit. Is that accurate? If you would just explain it a little
Chairman,
bit.
I'm going to speak to the science.
Absolutely.
And the science is that a C recommendation does mean a small net benefit.
Right.
And we map that C recommendation to advice that women make the decision with their doctors about whether or not to undergo skiing. I think this committee is dealing with incredibly complicated issues about health reform and coverage, but the task force is not a coverage and health care reform and policy committee. We're scientists.
But the bottom line is, and I'll end with this, is that even when you recommend a C, you're saying there's a small net benefit. So, again, let's not talk about today, but let's talk about if the bill that we passed in the House and this committee becomes law. Even then, the Secretary could say, okay, there's a small net benefit, and so we do want to require this as a basic benefit. Or, you basically leave it up to the insurance companies to decide the way they do today. But, the misinformation out there, I think, is that even under the bill that we passed, for once, there is going to be a requirement that some of these screenings occur. If you rate it as an A, it has to be done. If you rate it as a B, it has to be done. If you rate it as a C, the Secretary can say it has to be done. Right now, there's nothing at all. And the Republicans in their alternative would continue the status quo that say, you don't have to cover anything. And I just appreciate it because I think you've helped me clarify it. I yield now to the gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman, because what we need in this country is a continued debate on the failed health care bill that we passed on the floor of the House. That's what we really need to do, and that's what we're doing today. And we're using, obviously, what happened through your process to make the claim, the short-term concern of a public option, which many of my colleagues on the other side has said is the gateway to a one-payer system. So when the government controls all the health care decisions in this country, they will eventually default to control costs through ration care. Now, the process, the scientific process that you've just admitted to, said there's a small net benefit. When there is decreased revenue available, the default will be, based upon 3962, just what you say on your website. Your website recommends against routine screening mammography in women aged 40 to 49. Do you think that this statement would be perceived by women younger than 50 that they should not get a mammogram on your website?
We have communicated very poorly about the C recommendation. It is clear that many women, many physicians, and certainly the media interpreted that language as if we were recommending against women in their 40s ever having a mammogram. That was not our intention.
I understand, but we're concerned of commissions. We're concerned of bureaucracy. We're concerned of ration care. We're concerned about bureaucrats saying there's no real net benefit. And then we go, yeah, it is right. It's exactly what we're concerned about. And that's why we're having this debate. In the bill, and Chairman Pallone, I think pretty adequately talked about the differences. We know that services with a rating of A and B must be included in an essential benefit package. In this case, with the highest rating of C, women would not receive, currently, if this was law, as is today, women in the C category would not receive this as a covered benefit under 3962. And that is part of our concern. And this does segue into the full health care debate. The commissioner on part of the bill, and I don't have the whole 2,000 pages, I just pulled out excerpts. The commissioner shall specify the benefits to be made available under exchange participating health benefits plans during each year. And then you can go further on. Basic, enhanced, and premium, and then the premium plus A, approved by the commissioner. And then you can go to the C section, which was, again, highlighted. And we continue to have preventative services, including those services recommended with a grade A or B by the Task Force on Clinical Preventative Services. So the this is, again, for a lot of us, an important debate. Do any of you know an individual who's been diagnosed for cancer between the ages of 40 and 49? Personally.
Oh, yes. I know many individuals who've been diagnosed with cancer
Dr.
between the
Cologne?
ages of 40 and 49.
Yes.
And then the other question, what about over the age of 74? Anyone who's been diagnosed with?
Yes.
Because although we're focusing on 40 to 49, in your report, over 74 has the I category. And we don't even know if it is. So what are we saying to those over the age of 74?
I speak to the evidence and to the mapping of the evidence to the task force recommendations.
And I appreciate that. And I only got 38 seconds, and I'm going to be punctual on my time. Part of this concern with H.R. 3962 is, as we said, the public option, the gateway to a one-payer system, eventually rationed care, and then a decision based upon the financial ability of the country to fund care across the spectrum, but also our seniors in our country. And again, this incomplete aspect for 74 bespeaks to the concern that if you're elderly in this country and we get to a one-payer system, there'll be decisions made not based upon health care, but on cost. And I yield back my time.
Thank you. Mr. Waxman, Chairman Waxman.
Thank you, Mr. Chairman. The health care bill that the Republicans are complaining about is not law. Yet your agency, Preventive Task Force, is in operation. This is set up under, is it set up under law?
Yes.
Okay, and your job isn't to make recommendations to insurance companies, is it?
That is correct.
Your job is to make recommendations on preventive services so that the latest science and information about the science is communicated to clinical practitioners. Isn't that your job?
That is correct.
And this is very useful information. Now, we are focused on the breast cancer issue, but that's not the only area where you've made recommendations. Isn't that true?
That is correct.
How many other areas have the task force made recommendations in the last couple of years, let's say?
Well, our current portfolio is 105 total, and we take up around 15 new or updated topics annually.
You've recommended that teenagers be screened for mental illness.
Yes, that was a new recommendation this year, Congressman, that we just came out with this. So this is new services that had not been recommended prior.
And there was a breastfeeding behavioral intervention recommendation.
That is correct.
And you've had a recommendation that aspirin for the prevention of cardiovascular disease be a way to prevent the disease. Is that right?
Correct.
So you've had a whole range. You say how many? 103?
105 total.
105 total. I'm assuming that none of the others have been as controversial as this particular one.
That is correct.
Okay, so we have a controversial issue because it challenges the accepted notion about the frequency of breast cancer screening, and we're going to hear a lot more about that from the next panel. But I want to have us look at the challenge that's being raised by some of the Republicans, which I think is all political. They're acting as if your recommendations, based on bringing the scientists who have the expertise, which are directed at clinical people, will be used to ration care. That's their argument. We're going to ration care. And they then say, well, that's because there's going to be a health care bill that will provide a requirement for minimum benefits. Now, there'll be minimum benefits in that you should have access to hospitals. You should have access to doctors. You should have access to pharmaceuticals. Your area is in the preventive area. And nothing could be more important to me than having the latest science on how to prevent diseases, because if we can prevent illnesses, we won't pay to treat them later. Your task force will continue in operation. You'll convene the scientists who are experts in different areas of prevention. Now, I guess the question, I'm not raising this to you, but the question is, how will your
recommendations affect the minimum benefits that will be required for health care insurers. Healthcare insurers could be a public insurance if that survives in this legislative process. It certainly would be private insurance. Right now, private insurance doesn't have to abide by your recommendations. Isn't that true?
That is correct.
And some of them cover these preventive services and some of them don't. Isn't that true?
That's correct.
It's their decision. But if we're going to provide subsidies for people to get insurance, and we're going to try to get a market where insurance companies compete against each other based on price and quality, we ought to make sure that all of them provide at least a minimum set of benefits. One of the star issues for Republicans is to have a lot of insurance plans that don't provide any minimum benefit at all. They can be cheaper if they don't provide minimum benefits. Well, I find that troubling. But let's say we're going to have minimum benefits, and you make a recommendation. Is your recommendation under the proposed bill automatically going to be in effect for all insurance? Do you know whether that to be the case?
Congressman, I'm not well versed.
You're not an expert on the bill, but let me explain what the new bill will do. The new bill will take your recommendations. They'll go to the Secretary. The Secretary will review them. The Secretary will have a notice of rule and comment and a public process, and then decide whether it's a minimum benefit. Now, a minimum benefit is a minimum benefit. It's not a maximum benefit. So if there's a recommendation, as you propose, on breast cancer screening, that will be not a requirement of insurance to do no more than that. It would be a recommendation that will require insurance companies to do that as a floor, not a ceiling. I just wanted to set this out because I think some people watching this hearing may get confused when they hear stories about bureaucrats or rationing care or the health care bill being a gateway to single payer. We expect a bill with competition and people to make choices between insurance plans, but we don't want the choices between insurance plans to be those who cover breast cancer screening and those who don't, but those with at least a minimum of preventive services that we could hope will prevent diseases and the need for paying for care for those diseases. Thank you, Mr. Chairman.
Thank you, Chairman Waxman. Next is the gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. Let me ask you a question. I've got the clinical guidelines, and I guess this is a reprint from the Annals of Internal Medicine, the last page of which is an appendix which lists the members of the U.S. Preventive Task Services. And a number of individuals are listed there. Their specialties are not. Is anyone on the list there a board-certified OB-GYN?
Yes, there are 2 board-certified OB-GYNs on the task force, and that is we usually have 2.
Okay, which are those 2 that are on the list that I have in front of me?
Kimberly Gregory and Wanda Nicholson.
Okay, and they both participated in this decision?
Kimberly Gregory was on the task force when this decision was voted. Wanda was not. There was another OBGYN on the task force when this topic was voted. That was George Sawaya, who is a professor of OBGYN at University of California, San Francisco.
Were these unanimous votes?
No, the votes were not unanimous.
Do we know how the individuals voted?
I can't recall. That is in the record, and we could make that information available to the committee if that's important.
I would like to see it. I don't know if the committee will deem it as important, but I would certainly appreciate the opportunity to see it. Now, is there a radiologist in this group?
No. No, there's no radiologist in this group.
Is that a problem?
The expertise of this panel has been called in question. The experts are individuals who have experience in screening science and prevention. Radiologists were consulted and reviewed the documents and the recommendations and provided input.
Well, let's wait till that finishes. It bothers me too. On the on this task force, then the majority of these individuals were primary care doctors. Was there a general surgeon on the board or on the task force?
Well, again, the experts are experts in primary care and prevention, and yes, there were, and I would have to count them, 4 primary care physicians on the task force currently and 4 at the time that these were voted.
But was there a general surgeon who specializes in
No, there was no
needle localization and breast biopsy?
No, there wasn't.
Okay.
They were consulted?
They were consulted. All right. What, and I apologize for being in and out, but we're doing like 9 simultaneous hearings today, and the financial services makeover requires some attention and thought as well. On the issue, though, of talking about, you said you factored in the psychological events surrounding a callback on a positive mammogram. You factored in the psychological cost, if you will, to the patient in that exchange. Do I understand that correctly?
Well, the issue was a qualitative assessment. Anxiety, psychological distress, inconvenience are all considered to be harms and potential harms. And again, it's a part of the net benefit equation.
When I was in schools back in the 1970s, I realized it was a long time ago, but mammographic screening was not, at least in the area where I went to school, that was not something that was done. You sent someone for a mammogram. It was kind of a big deal because you felt something, but it wasn't done as just part of a routine screening. In fact, I don't think, as I recall, looking back, it was probably the mid-'80s when that became a standardized screening test. And in fact, in Texas, I don't know whether this is true nationwide, but in Texas, I know women can self-refer for mammography. When that all happened, that psychological cost was one of the arguments that was used by people who felt that routine screening would not be a good idea. So how is it that we've come to the point now where we rejected it back in the 1980s, but now in 2009, this is a factor again that's worthy of our consideration?
Again, this is not determinative. It's information that we want women to know about. We want them to know how common it is. Again, the false positive rate is much lower as women get older, and that's part of the net risk-benefit equation. We would not want women to be afraid of having a mammography. This is, again, one piece of information that women and their physicians should discuss when deciding when to start screening.
And does that same rationale apply to self-examination?
The task force recommended against clinicians teaching women breast self-examination. They did not recommend that women not pay attention to their bodies, that they ignore lumps, or that they ignore problems that might come up when they find a lump. Again, the task force recommendation was against doctors teaching women breast self-examination. Well,
How are women supposed to get that knowledge? They can't just get it by intuition. Someone somewhere along the line has got to provide them some guidelines on proper time to do the exam and how to do it and what to be concerned about and what not to be concerned about. Now, as I recall, now I may be wrong on this, but I don't ever recall coding and being compensated for teaching breast self-exam. So it's not I wasn't a cost center for you. I wasn't a cost driver. My only inference from that could be that you're worried that people will find things that then lead to procedures, and we're better off if we don't ask, don't tell.
Again, the evidence, there have been 2 very well-conducted randomized clinical trials in which women were taught how to do breast self-examination, And both of those trials found no overall benefit in terms of reducing mortality from breast cancer. Again, we go to the evidence.
Well,
Gentleman's
and
time
I will
has
say
expired.
anecdotally, as I said in my opening
Mr.
statement,
Burgess?
that it does.
Mr. Burgess,
it does
you're
strike
over
me that
2 minutes over your
It
time.
does strike me that the
Mr.
vast
Burgess.
amount of disease was brought to my attention by the patient herself. And again, as a young
Dr. Burgess,
age, I
time
learned
has
to take people
expired.
seriously. I'll just be interested in what some of the other clinicians tell us when they get their chance to testify. Thank you, Chairman.
Dr. Burgess, you're almost 3 minutes over, and we're about to vote. I think we have time for one more set of questions, and then we're going to vote. We have 5 votes. We'll take one more set of questions, and then we'll adjourn and come back after the 5 votes. Next is Chairman Dingell. Did you want to proceed now?
I think I could proceed rather quickly, Mr. Chairman. Yes, please. I'd like to welcome you both to the committee and tell you how helpful it is to have you here. From the things I've heard said on the other side of the aisle about you folks at the agency, I was afraid you'd appear with horns, tail, fangs, and in a red suit, breathing fire, demanding that we immediately terminate all health benefits for the unfortunate, sick, weak, poor, and especially with regard to mammograms and pap smears. So I'm very much comforted. I want to welcome you to the committee this morning. I just have really one question that I think is important. I find it curious that the task force has repeatedly, over the years, voted to leave costs out of its deliberations on whether to provide or not a proved preventive service. Why?
Thank you, Congressman. I think this is a key question. The task force believes its major charge from Congress and responsibility to primary care clinicians and patients is that we set the evidence-based stake in the ground immune from how much it costs to achieve the benefits associated with a given effective preventive service. So
your short answer is that you are recommending the needed services, the needed tests, the needed treatments, as opposed to looking at the cost. Is that it?
That is correct.
Okay. Now, to assist my colleagues on the other side of the aisle, and I do this out of great affection and respect and charity, you address this question in your statement, and you say here, and I read this for the benefit of my colleagues on the other side, you say task force recommendations are based on consideration of the health benefits and health harms of providing the preventive service and on the scientific certainty of whether the preventive service works. Cost and cost effectiveness of specific prevention services are not addressed by the task force in its deliberation. Then you say this, the task force only, and that's underlined, considers scientific evidence of health benefits and health harms. The task force has specifically discussed whether cost should influence a recommendation and has repeatedly voted to leave costs out of deliberations on whether or not to provide a preventive service. Is that right?
That is correct.
Now, when your recommendations are made, are they used to put a ceiling on benefits, or are they used to describe a minimum level of benefits that people should get?
Congressman, I must admit that it's outside the scope of our recommendations how they're used by other entities.
Okay. Now, your recommendations are not expected to be substituted for the need of the patient, for the concerns and expertise of the doctor, and they're not intended to intrude into the doctor-patient relationship. Am I correct in that interpretation, or am I wrong?
That is correct. In fact, if you read our statement as published in the Annals, it says, the task force recognizes that clinical or policy decisions involve more considerations than this body of evidence alone. Clinicians should understand the evidence and individualize decision-making to the specific patient or situation. This actually precedes all recommendations. It is a recommendation statement, and we expect clinicians to do what they're trained to do in order to address the needs of the individual patient for his or her best interest.
Now, you do permit, as the task force goes about its business, to have different agencies and persons of concern present in the deliberations. Is that not so?
That is correct.
And your deliberations are public?
At this point, the deliberations of a task force vote are by invitation only.
But by invitation. But you don't gag the people who come in to listen. They can go out and say what's going on. And they also are permitted to make comments to you on the task force. Is that not so?
We actually invite comments from our partners to help us do our job better and to take into consideration different viewpoints and different issues.
And you allow citizen input?
The task force is currently moving towards increased private citizen input with the resources we have available to consider and identify those. We have, prior to this time, done more with input through specific groups that we invite to comment because we think they're important stakeholders. This is an issue that the task force believes that in the interest of enhanced transparency and responsibility to the American public and the patients whose physicians may consider our recommendation needs to be improved.
Thank you, Mr. Chairman. Thank you.
Thank you, Chairman Dingle. We have 5 votes, I would say about an hour, but when they're done, we'll come back and reconvene. Committee stands in recess.